Good morning, everyone. The topic of my presentation today is early onset schizophrenia, and my moderator is Dr. Shobhit Joik, sir. So, I would like to start this presentation by sharing with you all a case report which I found out of a 6-year-old boy who developed very early onset schizophrenia. So, before starting this case report, we'll be going through these terms of early onset schizophrenia and very early onset schizophrenia in the subsequent slides. But for the time being, very early onset schizophrenia means schizophrenia which develops before 13 years of age, and early onset is which develops before 18 years of age. So this case report is about a young boy named Kyle who had presented to the hospital with a 1 month history of disorganized behavior, hallucinations, and developmental regression. So, according to this case report, let's just go through the developmental history of the child. So, when the child was 3 months old, he had began tracking objects his parents were unable to see. And at 7 months old, he began visually fixating on unseen objects and would open his eyes widely, become very excited, flap his arms, and tense his legs, according to his mother. Then, till 20 months old, he did not begin walking. At age of 3, he began talking to someone his parents would not see and leading them to believe that the child may have imaginary friends. Now, while learning to read at the age of 5, he would say, "Stop, mom, the words are talking back." This possibly suggests an experience of auditory hallucination which is being experienced by the child. So, in kindergarten, he was held back due to poor attention but remained socially interactive without grossly abnormal behavior. Just 1 month prior to the admission, he had developed frank hallucinations and social withdrawal. He would frequently whisper to himself and was so internally preoccupied that he was unable to follow any commands. Now, the patient's family history, it was positive for schizophrenia in a maternal cousin, two paternal cousins, and his paternal great grandmother, bipolar disorder in two paternal cousins, and autism in paternal cousin and a paternal great aunt. On initial evaluation, the child had appeared very thin and younger to his stated age. His mother stated that he had been eating only intermittently, resulting in significant weight loss and failure to thrive. His behavior was notable for stereotyped pursing of the lips, repetitive blinking, and poor eye contact. The child was mumbling to himself, and upon questioning, his speech was impoverished and disorganized. Now, the effect of the child was flat and it was intermittently guarded. He endorsed visual hallucinations of people in his eyes who were following him everywhere, named Shivani, James, and Jack, who appeared black with yellow teeth and green eyes. The child's mother endorsed that he had a history of paranoid delusions that people were chasing him or taking away his food. He also experienced passive suicidal ideation, saying, God, it's time for me to come to heaven, as well as homicidal ideation towards an unclear target, saying, I'm going to cut you up, I'm going to kill you. He did not exhibit injurious or violent behavior. Now, on admission, the patient had received a comprehensive medical workup, which I have not mentioned here, but the consulting psychiatrist deferred initiation of any antipsychotic medications given the young age of the patient and had instead started him on clonazepam for agitation control. Given the patient's unusually young age at presentation, possible lifelong symptoms, and a strong family history, a genetic testing was done, which had revealed a 22q11.2 deletion syndrome, which is basically velocardiofacial syndrome. In this syndrome, basically 25% of the patients have psychotic symptoms. They further develop psychotic symptoms. So now let us, after this case report, let us come to the scheme of the presentation of this. So we'll be going through, first of all, the definitions, then what is the incidence and prevalence, what is the diagnostic difficulty in childhood onset schizophrenia, the diagnostic criteria, differential diagnosis, assessment, treatment, prognosis, and summary. So first of all, the introductory part. So childhood onset schizophrenia is first of all a very rare illness due to which it is poorly understood, and hence due to the poor understanding, it is often misdiagnosed. Now, it was in the late 1930s that it was recognized as an independent diagnosis. So let us come to the definitions now. So early onset schizophrenia is defined as beginning before the patient's 18th birthday and very early onset before the patient's 13th birthday. So very early onset is a subtype of early onset only. And childhood onset schizophrenia is also known as prepubertal schizophrenia, like even though it is defined not in relation to the developmental age, but rather in relation to the patient's chronological age. So childhood onset is before 12 years or younger, and adolescent onset is between 13 and 17 years. So these are the four terms, but these terms have still not incorporated into the classification systems. Now, very early onset schizophrenia, as we had seen in the case report, which is before 13 years of age, is a progressively worsening developmental disorder for the following reasons. Over the course of this disorder, the cerebral ventricles enlarge, the cerebellum becomes smaller, and there is progressive gray matter loss into adolescence and further into adulthood. Intellectual dysfunction deteriorates over time. The outcome is highly unfavorable in comparison to that of adolescent onset and adult onset schizophrenia. And the transition from positive to negative manifestations begins during inpatient treatment and later stabilizes over the long-term course. So the prevalence and incidence. The lifetime prevalence of schizophrenia is about 1%. In adulthood, the incidence of schizophrenia has remained stable over the last 50 years across many different countries and cultures at 1 to 2 cases per 10,000 persons per year. Now, before 15 years of age, almost about 4% of cases of schizophrenia arise. Before 10 years, 1%. And studies of sample clinical population have revealed that about 10% of cases of schizophrenia arise between 14 and 20 years and 42% between ages 21 to 30 years. About two-thirds of all the patients with schizophrenia are between 20 and 40 years of age. So the sex differences, boys and girls are about equally represented among children and adolescents with schizophrenia, but there's still a mild predominance of boys. Now, why is it so difficult to diagnose? Because it is a very rare illness and it is poorly understood. Now, there is difficulty in diagnosis because distinguishing between true hallucinations and delusions and a child's imaginative play is very different. A child may have imaginary friends which can be mistaken for psychosis. Children with poor or underdeveloped language skills may mimic the disorganized thought and speech patterns observed in schizophrenia. Also, children will not be able to describe their experiences and symptoms due to a restricted vocabulary or a limited understanding of their own internal experiences. Now, in cases of childhood onset schizophrenia, there are often disturbances in the child's psychosocial functioning prior to the onset of illness, which are referred to as pre-morbid abnormalities. Pre-morbid abnormalities may include a range of behaviors such as shyness, introversion, loneliness, depression, aggression, suicidality, theft, and manic-like or bizarre behavior. One of the most commonly reported initial presenting issues in children is that they are struggling in school, which may be a direct result of the behavioral difficulties that arise in childhood onset schizophrenia. Problematic behaviors are typically noted upon entering school at the age of 5 or 6, although families often report that the disruptive behaviors began prior to schooling. Now the diagnosis. So childhood onset schizophrenia is diagnosed according to the same adult onset criteria, with the exception of criteria B. This is as per DSM-5, which states that the criteria B in DSM-5 states that the afflicted individual's level of functioning must be diminished. However, as this is difficult to assess in children, they instead must fail to meet the expected level of functioning for a child according to their age. So let us look at the comparative nosology as per DSM-5, ICD-11 and ICD-10. So DSM-5, we all know that out of the criteria A, out of the 5 symptoms, delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior and negative symptoms, 2 or more should be present and 1 should be present from either 1, 2 or 3. Then criteria B is for work functioning impairment. That is there should be a significant portion of time since the onset of disturbance wherein the level of functioning in 1 or more criteria such as work, interpersonal relations or self-care is markedly below the level achieved prior to onset. Now, criteria C is that the continuous signs of the disturbance persist for at least 6 months, and in these 6 months, 1 month of the symptoms should be of the active phase, and rest may include periods of prodromal or residual symptoms. Criteria D is schizoaffective disorder, depressive disorder, bipolar disorder, and with psychotic features should have been ruled out. Criteria E is the disturbance is not attributable to the psychological effects of any substance or any medical condition. Criteria F is if there is history of autism spectrum disorder or a communication disorder of childhood onset, the additional diagnosis of schizophrenia is made only if predominant hallucinations or delusions in addition to other required symptoms of schizophrenia are also present for at least 1 month. Now, these are the subspecifiers. First episode currently in acute episode. First episode currently in partial remission. Yes. Then, as per ICD-11, the diagnostic criteria is almost same to that of ICD-10. That at least 2 of the following symptoms must be present by the individual's report or through observation by clinician or other informants, most of the time for a period of 1 month or more, and at least one should be present from these 4, that is persistent delusion, persistent hallucinations, disorganized thinking, formal thought disorder, and experience of influence, passivity, or control. Then we have E2H criteria, which include negative symptoms, grossly disorganized behavior that impedes goal-directed activity, psychomotor disturbances such as catatonic restlessness, agitation, posturing, waxy flexibility, negativism, mutism, or stupor. The symptoms are not a manifestation of another medical condition and are not due to the effects of a substance or medications. Now, these are the subspecifiers again. Schizophrenia, first episode, multiple episodes, and continuous, which further include currently symptomatic, in partial remission, in full remission, and unspecified. Other specified episode of schizophrenia, episode unspecified. Now, as per ICD-10, similar diagnostic criteria, that is a minimum of 1 very clear-cut symptoms and usually 2 or more if less clear-cut, belonging to any one of the groups listed as A to D, or symptoms from at least 2 of the groups referred to as E to H, which are the thought phenomena, thought echo, insertion, withdrawal, or broadcasting, delusions of control, influence, passivity, clearly referred to as body or limb movements, hallucinatory voices, persistent delusions of other kinds that are culturally inappropriate and completely impossible, such as religious or political identity or superhuman powers and abilities. Then from E to I, persistent hallucinations in any modality when accompanied either by fleeting or half-formed delusions, breaks or interpolations in the train of thought, catatonic behavior, negative symptoms, and a significant and consistent change in the overall quality of some aspects of personal behavior, manifesting as loss of interest, aimlessness, idleness, a self-absorbed attitude, and social withdrawal. So these were the diagnostic criteria. Now let us come to the differential diagnosis. Now the presence of overlapping symptomatology and comorbid disorders and the early age at which children experience psychotic-like symptoms can make it very difficult to accurately diagnose childhood onset schizophrenia. Now the differential diagnosis include autism, disintegrative disorder, multiple developmental impairment, affective psychosis, Asperger's syndrome, drug-induced psychosis, organic brain disorders. Among these, the closest differentials are bipolar disorder, autism spectrum disorder, and ADHD. Now, the commonalities are between bipolar disorder and childhood onset schizophrenia. They can both present with psychotic symptoms, delusions, hallucinations, disorganized behavior, catatonia, and paranoia. But the distinguishing features are that in bipolar disorder, there are mood congruent delusions, and delusions and hallucinations occur exclusively during depression or mania. In autism spectrum disorder, the commonalities can be disorganized speech, flat affect, social deficits, and repetitive or bizarre movements. But in ASD, no hallucinations or delusions, and there is lack of atypical views. In ADHD, the common things can be poor attention and disorganized, and the distinguishing features are absence of a psychotic episode. Now, these are the various physical investigations which can be done in child and adolescent onset psychosis. We can do a urine drug screen. The target disorders are drug-related psychosis, and EEG for complex partial seizures, and MRI brain scan for ventricular enlargement, structural brain abnormalities, enlarged caudate, demyelination, hypodense basal ganglia. Serum copper and ceruloplasmin or urinary copper can be done to rule out Wilson's disease. Aryl sulfatase A for metachromatic leukodystrophy, and then cytogenetics karyotype for sex chromosome aneuploidies and velocardiofacial syndrome, that is 22q11 microdeletion. and anti-NMDA IgG antibodies for NMDA receptor encephalitis. Now the assessment. Unfortunately, there is no one test or procedure that can determine the presence of childhood onset schizophrenia, which is one of the many reasons why schizophrenia is difficult to diagnose in children. But there are certain scales which have been mentioned. For example, the schedule for affective disorders and schizophrenia, the PANSS, positive and negative symptom scale, and the pre-morbid adjustment scale. So first of all, let us just go through the Canon score pre-morbid adjustment scale. So this is a scale which basically rates 5 domains of functioning and a general section of items about quality of life. The 5 domains which are scaled are sociability and withdrawal, peer relationships, scholastic performance, adaptation to school, and socio-sexual aspects of life. And it covers 4 life periods, that is childhood, early adolescence, late adolescence, and adulthood. So in this scale, we have for each age group, for example, for childhood, these 5 of these domains are rated, and then for early adolescent the questions are different, and then again these 5 domains are rated. So as per the age groups, these domains are rated separately, and there are separate questions as well. So this scale, the pre-morbid adjustment scale, is to be administered for life periods up to 1 year before the onset of psychotic illness, and these are basically based on interviews with the children, the parents, and or any family members. And this is basically a Likert type scale of from 0 to 6, where the normal lower numbers would indicate normal healthy functioning and higher numbers indicate a pathologic development. So the rating of the scale is basically done for all the subscales. The score for each subscale, the score is calculated by dividing the obtained score by the total possible score for that scale, and then an average of all the 5 scales is taken. And the lower numbers would suggest, the lower scale would suggest that a more better functioning, a more better pre-morbid adjusted personality. The next is the KIDI SADS scale. SADS is schedule for affective disorders and schizophrenia, and K is KIDI. So this is a scale which has been, the KIDI SADS scale has been developed to diagnose current and past episodes of psychopathology in children and adolescents as per DSM-5 criteria. So this is a large scale, and it basically it supplements a lot of disorders, amongst which are as mentioned, the depressive and bipolar related disorders, and schizophrenia spectrum and other psychotic disorders, anxiety, obsessive compulsive and trauma related disorders, neurodevelopmental disruptive conduct disorders, eating disorders, and substance related disorders. So for each disorder, the scale is different and the scoring is different. Next is the positive and negative symptom scale, the PANSS scale, which is used for measuring symptom severity of patients with schizophrenia. And it was published in 1987 by Stanley K. Lewis Opler and Abraham Fisby. So this is the PANSS scale which we usually perform, which we usually do. So it has 7 positive items, 7 negative items, and then 16 general items. And then they are scaled as from 1 to 7, from absent to extreme. So this is the rating criteria. The start 1 is no symptom is present, 2 is minimal, that is questionable or subtle or suspected pathology may be there. 3 is mild, that is the symptom is clearly established but it is not pronounced enough. 4 is moderate, that it is clearly established but occurs only occasionally. And 5 is moderately severe, that it is not all time consuming but it impacts one's functioning. 6 is severe, that is highly disruptive to the patient, and 7 is extreme. Next, we come to the brain imaging studies which have been done in childhood onset schizophrenia. Since childhood onset schizophrenia, as we previously mentioned, is a rare illness, so the imaging studies are also very scarce. But on MRI, there's a general agreement on findings of increased lateral ventricular volume, decreased gray matter volume, and increased basal ganglia volume. Also, the functional imaging studies are very less, because functional imaging studies they demand patients to be immobile for fixed periods of time and carry out some cognitive tasks, as well as they involve radiation exposure, like as in positron emission tomography. So these are rarely done in children. Now there is there is a specific pattern of gray matter loss seen in childhood onset schizophrenia. So the initial analysis of childhood onset schizophrenia patients has showed a unique wave of back to front tissue loss, and our gray matter maturation also occurs in the same way, from back to front. So the tissue loss is from the early parietal gray matter loss, followed by frontal and temporal gray matter loss later in adolescence. And on the medial side, there's a top-down fashion loss and maturation as well. So a similar pattern of gray matter maturation was seen in healthy children, with suggesting that gray matter loss in childhood onset schizophrenia may reflect an exaggeration of the normal maturation process of synaptic or dendritic pruning during adolescence. These findings seem to be diagnostically specific, as they were not seen in children with atypical and affective psychosis who are receiving the same medications. As childhood onset schizophrenia subjects mature, the robust and global gray matter loss during the adolescent years become limited to the prefrontal and superior temporal cortices by the age of 24, mimicking a pattern seen in adult patients. So this is a diagram which is showing, the above part is showing normal gray matter maturation and the lower one is gray matter loss. So as we said, there's a wave from back to front. So from back to front, the gray matter maturation also occurs in this sequence, and the gray matter loss is also occurs in same sequence. The red and pink is suggesting loss. So we can see it is basically coming from the back. It is progressing from the back to the front, and also the maturation, it is progressing from the back to the front. Then on the medial side, as we said, there's a top to down loss and maturation as well. So we see that from the top to down, there is gray matter maturation. Also from top to down, there is gray matter loss. So this is another diagram showing back from here, the occipital area to the frontal, back to front progressive reduction. So there is frontal progressive reduction in childhood onset schizophrenia siblings. There is temporal progressive reduction. Occipital, there are subtle changes not seen by adulthood. Parietal, profound early reduction in childhood onset schizophrenia. Genetic studies. High resolution banding karyotype and FISH, basically fluorescent in situ hybridization analysis, are done routinely on all COS patients to look for major chromosomal abnormalities such as Fragile X and 22q11 deletions, Smith-Magen's, and 15q11 Q13 deletions. Now, 22q11 deletion syndrome, which manifests as velocardiofacial syndrome, is estimated to occur in 1 of 4,000 live births and is a known risk factor for schizophrenia. Now let us come to the treatment. So the treatment of childhood onset schizophrenia requires an interdisciplinary team of healthcare workers, which include psychiatrists, psychologists, pediatricians, social workers, and psychiatric nurses. The primary form of treatment for schizophrenia, including COS, is antipsychotic medications. Although very few studies have examined the efficacy and safety of antipsychotic use in children, they continue to be the first-line treatment for schizophrenia with this population. So this table shows the forms of treatment. The atypical antipsychotics which are usually prescribed are clozapine, risperidone, and olanzapine. Typically, antipsychotics are not prescribed in children owing to their side effects. And there are other therapies as well, that is individual therapy, family therapy, and further rehabilitation and psychoeducation. Now, atypical antipsychotics are usually the first medications used in treatment of childhood onset schizophrenia, as they tend to have fewer side effects than their counterparts. Now, clozapine can have particularly dangerous side effects when they're used to treat children with schizophrenia, the most severe of which is neutropenia. Now, in a study among a sample of 87 children and adolescents being treated with clozapine, approximately half of them displayed mild to moderate neutropenia, which is much higher than the risk of neutropenia in adults. The majority of these medications have not been FDA approved for use on children, with the exception of trifluoperazine, which has been approved for the treatment of schizophrenia in children between the ages of 6 and 12 years old and thiamidazole. Now, then we have the individualized therapy and the family therapies. Individualized therapy with children can reduce their symptoms by helping them to learn how to cope up with various stressors and challenges of living with schizophrenia. Therapy can help children improve their academic success, resolve difficulties at school, and improve their ability to maintain relationships with peers. The family therapy. Now, the family therapy focuses on providing not only the child, but the family unit also with support and education in coping with a child's illness. Working with the family unit rather than the individual child is beneficial because it can help the family develop a more positive style of interaction. Now, family members often fill the role of caregiver and As a result, may themselves suffer from depression, anxiety, feel burdened, and become critical or negative towards the child with schizophrenia. By improving the family dynamics, the goal is that the individual with schizophrenia will in turn have lower anxiety and depression, thus decreasing the likelihood of a relapse. Family intervention for individuals with schizophrenia has been shown to reduce patient relapse rates both during and following treatment and appears to reduce the likelihood that patients will require hospitalization during the post treatment. Now, the predictors of the disease course. The following predictors have for a chronic long-term course of schizophrenia beginning in childhood or adolescence have been identified. So, a family history of so these are basically the bad prognostic markers. Family history of schizophrenic psychosis, young age at onset and insidious onset, low pre-morbid level of psychosocial adaptation, developmental delays, long duration of first episode, large number of episodes, poor psychosocial adaptation at the time of discharge from the initial hospitalization, high load of disease manifestations at the time of discharge from initial hospitalization. Now, the summary. So, schizophrenic psychosis that arise before the age of 13 have a very poor prognosis. The disease usually continues to progress in adolescence and adulthood, and it can be diagnosed as the same criteria for adult schizophrenia. Patients whose disease is of acute onset with progressive schizophrenic manifestation, productive schizophrenic manifestations such as hallucinations and delusions have a better prognosis than those who have an insidious onset and have negative symptoms. The patient's pre-morbid personality also has a major role. Now, patients who were described as socially active, intelligent, integrated children and adolescents before they became ill have a better prognosis than those children who were intellectually impaired, timid, introverted, and uncommunicative before they became ill. The prognosis seems to be better for patients with no family history of schizophrenia and whose families which cooperate well. The few available studies on outcome and course of schizophrenia beginning in childhood and early adolescence confirm that they are much worse than adult onset schizophrenia. And a 42-year longitudinal study of patients with COS revealed their suicide rates to be higher than that of patients with adult onset schizophrenia. No further longitudinal studies are available to confirm this finding. These are my references. Thank you.
I think after this comprehensive presentation, the floor is open for any questions, comments, or clarifications.
No, basically, both adults onset and children, childhood onset schizophrenia, they have similar, either positive symptoms or negative symptoms. But the difficult part is that in children, it is very difficult to basically come up with the delusions and hallucinations because children will not be able to describe their experiences. And then distinguishing that whether these are real or these are, for example, a child's imagination, also due to the child's restricted vocabulary, it becomes very difficult to diagnose.
How will you diagnose differentiate imaginative play and hallucination?
So in a child, it's very difficult.
Particularly imaginative play is present. The child is scared. Hallucination means that the child is scared. Effectively, you can see that he disturbed. You can judge that, okay, but they sometimes even when the child is disturbed and describes, people take it as imaginative. Usually, children do not like they are embarrassed maybe to tell about their imaginative play if they're older, but they find it effectively they are disturbed. At times, you find that imaginative play happening in class while the child is in class, and situations become very inappropriate. So child is not alone or not in the playing environment, still he is involved. So you'll get that indirect indicator that this pretty abnormal behavior. You said about male female differences. Yes. What about the onset gender differences in now?
So no onset difference has been found.
Yeah, there is binary onset or in children. In general, schizophrenia, male and female, it has a related onset. In males, the onset is a little earlier. So when you compare it to females, it you see the prevalence, gender-based prevalence, it's overall equal. Lifetime prevalence is equal because of the later surge in prevalence. Post-menopausal surge again. Questions? Can you explain that maturation? Little unclear. So this we understood that maturation is happening and also the regression is happening in the same pattern. The next diagram.
So the next
is
diagram
the
is
next.
so this is just a summary of the previous two diagrams that there is a wave from back to front and the parietal loss is first and then we have the frontal loss. So this diagram is basically just showing that there is a reduction in gray matter in the parietal area, in the frontal area and in the temporal area as well.
Why not in occipital area?
So occipital, it was said that there are not many changes.
Occipital is starting
From the back to the front. Yes, sir.
Back to front, and that means maturations are getting very late in frontal area. That is very low. That it actually now happens till 23, 24 years of age. And then they are saying that abnormal pruning is also happening the similar pattern. So occipital lobe is relatively spared. So that is a reason. Because that is why we don't see the visual hallucinations only in functional in schizophrenia proper. But we see auditory hallucinations very prominently because of the involvement. So it needs more clarity.
Yes, ma'am. But in parietal also there is profound more than parietal.
Any questions? First years? Negi? Dr. Bishri? Ranusha? So have you seen any case till now? Early onset schizophrenia before 18? नहीं मुझे भी सारे cases आते हैं. Talking about a very early onset. Dr. Sarthak. Dr. Ayushi. It's a very interesting topic.
So one was of a girl struggling and second was there was a differential. So there was a boy named Shitin who got admitted in a paper. So they had the first patient was autism, but it was it was really the child was moved in this as well. I don't know if it could come to
There was another patient that was maybe was diagnosed with schizophrenia, was under I think 2 or 3 antipsychotics and very disturbed. We admitted him and forgetting his name was number 3, I think.
Yes, sir.
And then we removed all his antipsychotics, we removed his antidepressants, and the diagnosis was revised to autism. We still follow up. So intermittently, he used to get very hostile attitude. It was mostly like it was not psychotic. It can be other way around. You can diagnose others as. I have one more question. What about the stability of the diet? Have you come across any study where child with schizophrenia diagnosed have remained to be schizophrenia or the diagnosis has changed in adulthood?
Sir, I have not actually come to the same question, but sir, there was one study which I read about, sir, in which an alternative 43 diagnosis was given to the child before coming up to child onset schizophrenia. But sir, I have not gone through any study as per your question that In other we didn't also have.
Previously, there was a lot of say bias towards schizophrenia and childhood bipolar. So a lot of people were diagnosed with schizophrenia later on turned out to be bipolar.
Yes.
And earlier on, every you can say agitation or anything was diagnosis schizophrenia. Second thing was that say autism, which is now a separate disorder. Earlier on, these symptoms were also thought to be of psychosis. Okay, in fact, the 4 A's there is the autism and also there. So a lot of autistic children were also earlier diagnosed with schizophrenia. The diagnostic criteria have changed over the period of time. All right. Then it was for some time thought that you can't diagnose schizophrenia with autism.
Yes.
So you can't have both the diagnosis. Now we can say we can make both the diagnosis. So historically, it has changed. Right. And now we have because we have different diagnoses. So that is also.
Aditi?
The psychological factors is that early age migration is the social isolation. So that you dopamine discrimination, that even childhood abuse and less than 100 and it is slightly more in boys compared to girls, 1.67. Apart from that, all of these things that Joseph that you mentioned, one more skill that was women represents that is a social communication question. Consists of 30 questions and takes not more than 10 minutes. The questions are like whether the child is able to have a meaningful conversation with you, whether he has some inappropriate conversations when in class. So this class. I was shared a case. My neighbor, she was hardly 10 years younger than me. As a child, also, retrospective, now she has schizophrenia at least. As a child, also, she was a very odd child. Like even at the age of 5 to 6 years, she used to defecate and pass urine in front of the house, in front of others. With 5 to because at that time there was no, I mean, how do I say, no awareness. So she was never taken to a doctor and everyone thought that she's an odd child. But she used to talk alone and talk to herself and everyone thought it is an imaginary play or something. In school also her academic performance was very poor. She somehow passed class 10, but after that she got frank symptoms. Like in teenager, if you hear like this, people then take it better. And now she's on treatment, but not she has not even achieved, I would say, full remission. She has never achieved. There's partial remission, but still, even with clozapine, the remission is not satisfactory. She still has hand symptoms of. Another patient I had, he had started with conversion. I mean, he was having this fainting spell, MRI, everything was normal. There was some quarrel at home, his father scolded him, and then he was fainting, and then while walking out, the conversion. And he came with this that presentation. He was discharged 20%. Then after 15 months, he came there, total negative symptoms. Mutism and muttering to self, I took it, not taking care of his hygiene also. He started in Molanzapine, came for around 1 year follow, but then subscribed to Clozapine, but there was not much improvement. They were so poor equilibrium. I mean, his father, and then it didn't follow. But initially, we had never thought that the conversion will go from.
So yes, so the regarding the presentation, you would have very good presentation and all the definition were there. Now, comment regarding the subject. I think the first thing that we need to understand is onset. When we say onset, now we know from the research that most of the patients of schizophrenia will have some impairment even earlier in the life. For example, academic, social, uh, finance, recently. So onset is described when you have a full blown picture of the in the ICD also when you say onset acute developed, it is when the whole it is diagnosable. Okay, so sometimes people confuse onset with start of disorder. It is not a start. It is when it becomes diagnosable. Okay, so for most patients of schizophrenia, you will see some problems even in childhood that does not make them childhood onset or early onset. Okay, it is when they become diagnosable. Even the case that you described is that where all the symptoms are there. Okay, so that is one thing. So second, I have a suggestion that whenever any say uh, patient below 18 is admitted, you all people should assess it because we see fewer patients in that category. And so there the presentation because that age group has a lot of even like both in the extremes of it, like in younger and in older patients. So this is different, it is difficult to assess. So once you start assessing the patients, then you will see that theoretically, which we see difficult, sometimes reality like imaginative play and hallucinations. Okay, things like that. So they become clear once you start assessing the patients. So that is the main thing.
I think very well pointed out. The whole point is that there are a lot of patients who are admitted before 18, as sir said, and I think probably you're not remembering those cases or you're attaching those cases because adolescents or teens they appear to be more of an adulthood. Many of these cases have been compounded by cannabis culture because they come with cannabis, but actually they break into psychosis. And subsequently, you can see very frequent issue that they don't take cannabis and they are into the same state for a very, very long period of time. But when we talk about childhood onset or very early onset schizophrenia, delusions are very difficult to get. What can help us is hallucinations because those are very evident. Because child will also, maybe initially, but later on, child will also not realize the irrationality. They are pretty difficult. One case, I think, an ADHD child, mother having schizophrenia, put him on stimulants. Initially, 3 years he responded very well. Subsequently, one day, father called that he's talking, sitting in class, he's talking to someone, and that is pretty abnormal, pretty nerve-wracking. So he was saying that whether he's having same symptoms as his mother. So we tapered stimulant and then no option because he was not tolerating any other stuff. Regarding treatment, Risperidone is a good option because it is recommended in your neurodevelopmental disorders. I think I asked Asta to look into various antipsychotics and minimum age recommended. So I think when we talk about Risperidone, 5 years is the age in neurodevelopmental disorders, and I think it was already 6 years. So we can use these two agents, and clozapine is at I think it is around 11 or 12 years of age. Is the minimum recommended age to be given. Now, clozapine has an evidence that earlier, if we start clozapine, subsequently it has some neuroprotective effects. So maybe we need more data that such an early insult to the brain, whether we are inviting a neuroprogression and a very bad guarded prognosis in these cases. So maybe early starting clozapine might help, but we need more data. As she shared, data is very less. Regarding presentation, there was one chapter, 2 to 3 editions before CPP, early onset schizophrenia. That became the motivation to give this. Because we don't see it, it becomes worth discussing. And she followed, she even quoted Rata because Rata is a beautifully written book. Anyone who want to go and read it. And also, as I asked her, she also included a case report. I asked her just to see what is the earliest diagnosed printable case in the literature which has been diagnosed schizophrenia. I think this was 6 years of age. I think before that it was very difficult. So in that sense, I think she has covered all the areas, presented well. Thank you.
Regarding the treatment, I was just saying that in the childhood cases, psychosis, acute psychosis, schizophrenia, it is my personal take. I always try to, because of the past that we have studied, we always try to taper down the medication and if possible, take them off the medication. Many times, like it is possible in acute psychosis and schizophrenia, even in acute schizophrenia like psychosis. Even in 1 out of 10 patients, if you can do, and it's okay. So that is my personal thing that because of the back in this, reliability of the diagnosis. Many times children become say disturbed early on. So I have had a few patients, and one of the patients is admitted right now, Vishaka. She was like admitted with acute psychosis early on, and she was like she maintained on like I kept on taping it down, and she was well on 25 milligrams clozapine for quite some time. I think in October, November I stopped it. She was doing fine, and again she has come back with symptoms, not exactly psychotic. So that is say also to always keep on questioning, at least in the say adolescent age and in the teenage, which we can think of some other
Personality disorder can be.
Yes.
I read it. Abroad and it's very good here. So in abroad, there is a more dropout comparing to the children and adolescents did not get remissions and they are included 600 studies and only those studies supported to the good outcome and if the patient also getting proper remission. And many children and adolescents did not get a proper remission due to their cognitive decline and maturity issues and independence issues, family support, social support, as well as family marital assessment issues. Due to that, they didn't get a proper remission.
Thank you.